Welcome to your most favorite channel, Heartbeat. My name is Dr. Najeebslectures. As a student, I say most of the teaching will be digitalized. Hard copies of books will become obsolete. They will be replaced by soft copies. Lectures and lecture halls will cease to exist. They will be substituted by videos and online classes. Practical classes will remain in medical sciences. We have to prepare ourselves for a revolution in learning and teaching methods in all disciplines. Today we learn something about arterial blood gases, examples. Channel's name is Heartbeat. My name is Dr. Najeebslectures. So, in the previous lectures, we've had a discussion on arterial blood gases, metabolicacidosis, metabolicalkalosis, respiratoryacitosis, and respiratoryalkalosis, and the interpretation has been already been discussed. In this lecture we'll just have examples. So there are various causes of mixed metabolic alkalosis and respiratory alkalosis. When both of them are mixed, you'll get a pH that increases, PaCO2 decreases, and is increase in bicarb. Examples are liver cirrhosis with diuretic use, hyperemesis gravidum, and excessive ventilation in COPD patients. Mixed respiratory acidosis and metabolic alkalosis can be seen in various conditions, and in this the pH decreases. This increase in PaCO2 and decrease in bicarb, such as cardiac arrest and multi-organ failure. So in the first example, we got a patient who's having a pH 7.5 on the arterial blood gases. So this goes in favor of alkalosis. It is more than 7.4. PaCO2 is 27, normal is around 40, and bicarb is 24, which is around the normal range. So PaCO2 is decreased, so it goes in favor of respiratory alkalosis. You got a patient who's got pH is 7.32, PaCO2 is 23 millimeters of mercury, which is low, and bicarb is 16. So this is acidosis 7.32 below 7.4, so it goes in favor of metabolic acidosis with respiratory compensation. See, the bicarb is very low and PaCO2 should have been 16 into 1.5, that's 24 plus minus 2, 23. So this complete compensation. And third, here is the pH 7.23, so pH is very low, acidosis. PaCO2 is 37, bicarb is 15. So, and PO2 is 94 millimeters mercury, and at FiO2 21. So this goes in favor of acidosis. Bicarb is low, so it can be metabolic acidosis. Now is there compensation or full compensation? It is metabolic acidosis. Example 4. pH is 7.25, so this goes in favor of acidosis. PaCO2 is 76, so this increase, normal value is around 40, and bicarb is also increased. So in proportion to the PaCO2, the bicarb is also increased. This is increased by around 36, and this is increased by 7. PO2 is 39 millimeters of mercury, and FiO2 is 21%. So it comes in favor of acute respiratory acidosis and uncompensated. Example 5. pH 7.36, so this goes in favor of acidosis. PaCO2 is 17, very low, and bicarb is 13. So this goes in favor of metabolic acidosis at PO2 109, FiO2 is 21, and if the bicarb is 13, PaCO2 is 17, both are reduced proportionately, so it goes in favor of compensated metabolic acidosis. Example 6. Here you get the pH 7.49, which is favor of alkalosis. PaCO2 is 17, which is reduced. Bicarb is 13, which is again reduced. PO2 is 110, and this is in favor of respiratory alkalosis because the pH is in alkalosis and PaCO2 is also decreased. Here you're getting pH 7.5, example number 7. So this goes in favor of alkalosis. PaCO2 is 47 and bicarb is 31, which is increased. So PO2 is 85, Fi2 is 35%. So it looks like metabolic alkalosis compensated. Here this alkalosis, bicarb is increased and PaCO2 has also increased. So it goes in favor of metabolic alkalosis compensated. Example 8. pH is 7.39. These are the most dangerous kinds of ABGs in which the pH is in the normal range. PaCO2 is increased. So it goes in favor of respiratory acidosis. Bicarb has also increased 31. PO2 is 62 millimeters of mercury. FiO2 is 21%. So it's respiratory acidosis with compensation. So in example number 9, you have a pH 7.39, PaCO2 49 millimeters of mercury, bicarb 27. Again, this is acidosis. PaCO2 is increased. Bicarb is almost increased by 10. Bicarb is almost increased proportionately. So this is chronic respiratory acidosis with metabolic alkalosis. Example 10. pH is 7.46. PaCO2 is 31 milliliters of mercury and bicarb is 22 millimoles per liter. So this goes in favor of uncompensated respiratory alkalosis. We see that pH is increased, PaCO2 is decreased and bicarb is almost the same. In example number 11, pH is 7.3, PaCO2 is 38. So this goes in favor of acidosis. PaCO2 is decreased and bicarb is also decreased. So this goes in favor of acidosis. Sodium we've been given here as 108, potassium 6.2 and chloride 72. So you have to calculate the anion gap in this, and it goes in favor of metabolic acidosis. Anion gap is approximately 17. So you get sodium minus bicarb minus chloride. So this nearly is equal to 18, perhaps 19, and delta gap is 17 minus 12 by 24 minus 19, which is equal to 5 by 5 and is equal to 1. These things, anion gap and delta gap, have been discussed previously in the previous videos. Now if you get a venous sample, pH 7.24, PaCO2 73 millimeters of mercury, so this goes in favor of acidosis, and bicarb again 33, so it goes in favor of respiratory acidosis. So many of the blood gases can be done by the venous sample also, and arterial is not required. PO2 is 16 millimeters, so this goes in favor of chronic respiratory acidosis.